Thank you everyone for joining us for the lunch session. And I'm going to go ahead and turn it over to Dr. Michael Devous, and he's going to talk to us about some of the research for Alzheimer's disease treatment.
Good afternoon, everybody. Thank you for joining us on this update on Alzheimer's disease treatment research. I'm fortunate to be a member of the board for the New Mexico Alzheimer's Association and a previous professor of radiology and neurology doing research in Alzheimer's disease, and more recently working for a division of Eli Lilly focused on developing new therapeutic drugs. There are a couple of introductory slides that I want to use to sort of set the stage for why this treatment research is so important and why the recent advances are such a key breakthrough for us. You probably know, but in case you don't, the timely diagnosis of Alzheimer's disease is a really big deal. It's an enormous unmet need because clinical diagnosis is difficult. It's often associated with up to a 30% error rate. So anything we can do to enhance early diagnosis is important. On average, diagnosis is 2 to 3 years, correct diagnosis anyway, is 2 to 3 years after symptom onset. About 20% of patients are misdiagnosed, and maybe as many as half of all patients with Alzheimer's disease never get a formal diagnosis. In addition, there have been no new medicines for Alzheimer's disease in more than a decade. With one exciting exception, last June, the very first therapeutic treatment drug, aducanumab, the brand name is Aduhelm, was approved by the FDA. The basics behind getting a good diagnosis is the mythology of the disease. There are 2 proteins that become abnormal in the brain during the course of the development of Alzheimer's disease. The first is beta amyloid, which is deposited between the neurons as amyloid plaques. And the second is a tau protein that gets deposited as what we call neurofibrillary tangles, tangled up proteins, and they aggregate inside the neurons. And both of these are neurotoxic. Amyloid comes first, often 15 to 20 years before symptom onset, and tangles occur about 5 to 10 years after amyloid occurs. This is an important thing to understand about clinical trials. Prior to rapid access to biomarkers, mostly through PET imaging, many patients were entered into clinical trials who did not actually have Alzheimer's disease. Here are examples from 3 different trials and from some autopsy data suggesting that about 20% of all the patients we were studying in clinical trials for Alzheimer's disease had no amyloid, and therefore they had no Alzheimer's disease. The way this affects a trial is portrayed in this slide. If you notice the x-axis, that this is time, the y-axis is change in a cognitive test or a functional test or something else. The patients with the dots, the ones without amyloid, are pretty stable over 1.5 to 2 years. They don't progress, while the patients with amyloid who really do have Alzheimer's disease progress. Imagine that those non-progressing patients are mixed into your treated and your placebo groups. That means that the patients who don't have amyloid, don't have Alzheimer's disease in the treatment group can't respond. So a response that might be occurring is somewhat masked. And the placebo group doesn't decline as fast as it ought to if it was all Alzheimer's patients, but in fact is slowed down in its apparent decline by those patients who don't actually have the disease. The use of biomarkers has become quite prevalent, not only in clinical trials, but also just in diagnosis and management of patients. The preeminent biomarker is amyloid. As I mentioned, it occurs very early. It's the first signal we can detect of the disease, and in fact is detectable in subjects who don't have any cognitive impairment at all, but are on the road to Alzheimer's disease. The next big biomarker is tau, the neurofibrillary tangles I mentioned before. As these 2 proteinopathies occur, as these proteins collect in the brain, you see degeneration of brain cells. They die, they become sick, they don't function as well as they ought to, and they die. When that happens, cognition declines, your ability to think goes down, and clinical function, what we call activities of daily living, decline. The combination of that whole pathway, the so-called amyloid hypothesis, is the result in dementia that we are sadly forced to deal with. What is the impact of PET imaging on clinical trials? Well, the first question we can address is, who should we treat? Can we rule out patients who don't really have this disease in our clinical trials? The second use for that is as a biomarker to enroll patients. So if I can find patients who do have amyloid, they might be reasonable ones to enroll in a trial. Then you might ask, how is your drug working? Does it work at all? This is an important distinction. I might enroll patients who have amyloid and give them an anti-amyloid drug and remove amyloid from the brain, but in fact have no impact on the course of the disease. So you need another biomarker that serves as a surrogate for the efficacy of your treatment. If you can take out amyloid, for example, and downstream, you stop the propagation of tau, you stop the accumulation of neurofibrillary tangles, then you have proved that your drug actually is changing the disease, not just the biomarker. So using amyloid PET, you can see a lot of amyloid in the brain in the picture on the left, going down to the blue colors on the right, because that patient has lost amyloid. And just below that, a tau PET scan showing lots of PET in the back of the brain that is removed over time. That first scan might be used for patient enrollment or patient stratification, and that second PET scan might be used as a surrogate marker for efficacy of the drug. But if you had an anti-tau drug, these two could change roles. One could be used for enrollment and one as a surrogate. Is there any sense in believing that these are useful? Well, we do have two drugs, at least, that have been well published that remove amyloid from the brain. On the left-hand side, you can see drug aducanumab, the one that was approved by the FDA in June, has removed amyloid in the patient scan on the left. And the plots show a steady decline in amyloid in patients who either got the low dose, the blue line, or the high dose of this drug over the course of this trial. So right is another drug, donanemab, that is in phase 3 trials now. You can see in patient A that it rapidly removed amyloid early in the course. In patient B, it removed amyloid, though it took a little bit longer. And you can see in these plots the time course of removal of amyloid. So we do have drugs that actually take amyloid out of the brain in living human beings. And in a little bit, we'll see how effective they might be on what we care about, which is cognitive function and clinical function. What about tau imaging as a biomarker instead of amyloid? On the left side, you see that young people just don't have any tau tangles in their brain. Older people who are cognitively normal, but who do have amyloid, have small amounts of tau in their temporal lobes, that sort of purple pinkish hue you see on these images. As you move from cognitive normal to mild cognitive impairment, the uptake and the distribution of tau increases, becomes more widespread and more intense, particularly in the temporal and occipital lobes. And then as you move on to people who actually have clinically diagnosed Alzheimer's disease, you can see that tau is more widespread, now affecting the frontal lobes in particular, which is a sign of advanced disease. Keep these pictures in mind because they have a big impact on how we will ultimately identify patients for clinical trials. While those pictures are averages of groups of subjects, each person has almost their own tau signature. This is a slide of 4 different patients. The first 2 have MCI. Their MMSE score, many mental state score, which is a score of cognitive status, is about the same. It's 27. And yet the areas of tau uptake are pretty different. The top patient, it's in the upper back portion of the brain. In the second row, it's more on the left side of the temporal lobe. The next patient down is quite a bit younger, only 54, but they have Alzheimer's disease, a worse MMSE, and you can see tau is everywhere. It's throughout the brain, this young patient. And just below that person, an 82-year-old dementia patient with the same MMSE has tau more extensively than the MCI patients, but in a more restricted area than the 50-year-old. These patterns turn to be quite meaningful. They tell us what kind of cognitive impairment to expect in patients and how rapid the decline is likely to be. So how would you use these tools, these tau and amyloid imaging tools, to develop the right therapies for the right patients? Well, we think we can use PET imaging and possibly other biomarkers like plasma biomarkers to identify a window for therapy. And this plot walks us through how that might be used. The orange line is fluortaucipir, that's a tau imaging agent. The red line is florbetapir, that's an amyloid imaging agent. And the green line is cognitive impairment. At the beginning, we could see modest elevations of fluortaucipir and florbetapir, frankly, in the medial temporal lobe early on. As the amyloid levels increase, without the tau levels increasing, you're beginning to get PET detectable levels of amyloid in subjects. Shortly after that, you start seeing an increase in tau as the amyloid levels go up. You can see that about 60 centiloids, which is a scale that we use to measure amyloid, that goes from 0 to 100. 0 is none, 100 is a lot, is occurring at the time that the tau PET pattern begins to become consistent with an AD diagnosis. That is, it has moved into the lateral temporal lobes of the posterior part of the brain. Then that tau PET pattern moves onward to distribute throughout more of the brain, indicating an imminent clinical decline. And then eventually you get a global tauopathy. That is, tau is everywhere, amyloid is everywhere. Patients have severe Alzheimer's disease. You might imagine that at that stage, patients are going to be very difficult to treat with an anti-amyloid therapy. By that point, tau has really taken over the brain, and tau is probably driving cognitive decline. So in patients who have that much tau, amyloid therapies may not be useful. If you go back to this stage where you start seeing amyloid, you probably have enough amyloid in the brain that patients will decline in cognitive function when not treated, and perhaps not decline or not decline so much when treated. This is really important distinction. If your placebo group is not declining, then you can't measure the effect of a drug. So you need to be far enough in the course that you're getting cognitive decline in the placebo group and not so far that the entire decline is driven by tau if you're exploring anti-amyloid therapies. Well, Biogen, who developed the aducanumab drug, used amyloid imaging in the way I described. What happens when you use amyloid to choose patients? Well, here are two different clinical trials they did. Their phase 3 trials were named Emerge and Engage. And in both of those trials, they were able to see a substantial decline in amyloid over time. Again, they used two different doses, a low dose in blue and a high dose in purple. And you can see really substantial removal of amyloid in both of these phase 3 trials. However, the clinical results, the cognitive function results, were less impressive. On the left, in the Emerge trial, there was a statistically significant improvement or slowing of cognitive decline, not an improvement in cognition, but a slowing of cognitive decline at high dose. But in the other phase 3 trial, there was no significant effect. We don't entirely understand why these trials weren't identical. Other data suggested that the left-hand panel was the correct way the drug would be used, and that's why the FDA approved it. And it is in use now, available, not yet reimbursed. CMS is still working on reimbursement decisions, but it is available for use. And Biogen is being required to conduct a phase 4 trial, that is a trial after approval, to try to understand how to achieve the results on the left all of the time.
Dr. Devous, there's a question, amyloid and tau biomarkers can help with Alzheimer's disease treatments, but what about other forms of dementia?
That's a really good question. So elevated amyloid is not a biomarker for, let's say, frontal lobe dementia or PSP or neurodegenerative diseases. That's not quite true of tau, however. Tau is elevated, though in different anatomic areas in PSP and in frontal lobe dementia. So it might be that a tau biomarker would be useful in some other neurodegenerative disorders, not so much amyloid. Here you have to be a little bit careful. Not all tau imaging agents are created equal. The one that is most widespread use, the fluortaucipir agent, really only detects the tau of Alzheimer's disease. So if you wanted to study PSP, for example, primary supranuclear palsy, you would probably want to use a different tau imaging agent. But for other neurodegenerative disorders, you might have to have something specific. You might have to have a biomarker for alpha-synuclein, for example, for Lewy body dementia. So yes, they can be used in other disorders, though amyloid is pretty specific to Alzheimer's disease.
And are doctors using more PET scans or MRI scans to see the brain?
Another excellent question. They're very different. MRI is almost universally used in working at patients with cognitive impairment because, though rarely, there can be changes due to tumors in the brain or other structural abnormalities that MRI can detect. So MRI will almost always be done to rule out those kinds of causes for the cognitive change. But otherwise, it doesn't tell you much about what is causing cognitive impairment. It doesn't tell you anything about whether it's Alzheimer's disease or frontal lobe dementia. It is really a structural imaging technique used to rule out structural abnormalities. So PET would dominate in the case of having done an MRI, finding no structural abnormalities, now what? And a PET scan might be a way to pursue what answer is. Is this Alzheimer's disease or is it something else? Okay. When you use amyloid and tau to define the patient groups, as was done by Eli Lilly in their donanemab trial, you get a somewhat different approach. So what Lilly did along the lines that I was describing earlier is they used amyloid to determine who had amyloid. And then among the amyloid positive potential patients, they ruled out the patients with very low tau because they would not progress enough to detect an impact of a therapy. And they ruled out those high tau patients where their cognitive decline is probably driven by neurofibrillary tangles and thus anti-amyloid therapy might not be effective. So this is different than the Biogen trial, which only used amyloid. This was only used amyloid. This trial used amyloid and tau. And when you did that, they got interesting results that are encouraging. On the left-hand side is the clearance of amyloid. And you can see that aducanumab cleared amyloid, certainly as I had already showed you, but donanemab cleared it faster and maybe a little bit more. And on the right side, it also slowed the accumulation of tau. The green lines are the tau accumulation with the therapeutic group, and gray is the placebo group. And you can see that there was less tau after therapy in the 5 regions shown on the plot than there would be in the placebo group. Does this matter? Well, that's the important question, isn't it? On the upper left-hand corner was the primary outcome. This scale called the IADRS is a mixture of cognitive and functional measures. And they demonstrated a 32% slowing in the treated group of decline on this combo measure. On the CDR clinical scale, 3% slowing. On the ADAS-Cog, a 39% slowing, et cetera. So a protective effect, the slowing of cognitive decline and functional decline was seen for every measure shown on this slide, as well as removal of amyloid and slowing of tau accumulation. Now, this is a phase 2 trial, so it doesn't mean this drug works perfectly or even works. It is now in a phase 3 trial. That's the ultimate determinant of whether it will be successful or not. But it's certainly encouraging that it has a widespread effect on both amyloid and tau and on clinical and functional measures. So what do we know from this sort of approach, from using biomarkers to design our clinical trials and to screen patients into or out of those trials? Well, we know that amyloid imaging can help select patients with amyloid pathology. And that tells you 2 things. First of all, it tells you that they have one of the primary biomarkers of Alzheimer's disease. And just to reiterate, if you don't have amyloid, you don't have Alzheimer's disease. If you do have amyloid, you might have Alzheimer's disease, but you have to have both amyloid and tau to have a definitive statement that that patient has Alzheimer's disease. So amyloid by itself can't rule in Alzheimer's disease, but it can rule it out. And of course, if you use amyloid imaging in an anti-amyloid therapy or any other kind of therapy trial, if you see a decline in amyloid, as was seen with lecanemab and donanemab, and by the way, bapineuzumab and several other drugs have been able to show decline or removal rather of amyloid, an impact of your drug on the intended target, on the amyloid plaques. Tau imaging helps us stratify patients for clinical trials to rule out patients who have so much tau that removing amyloid is unlikely to benefit them, and to rule out patients who have so little tau they're not going to decline enough to detect a therapeutic effect. So in a sense, you improve the homogeneity of the patients who undergo a clinical trial. We're a more homogeneous group, more likely to tell us whether our drug is really working or not. And it helps us detect the placebo response, right? Which should be real decline in patients stratified this way. It's also relevant, as I mentioned, in identification of AD pathology. The gold standard, of course, is at autopsy, finding both amyloid plaques and tau neurofibrillary tangles. Now, in life, we can identify people who have both of those biomarkers and thus have the two confirmatory biomarkers of Alzheimer's disease. We know statistically that 60 to 70% of all dementia patients are going to have Alzheimer's disease. But if you're a specific patient, you'd like to know, is that me or not? You caregivers, you guys might want to know, is that my brother, sister, mother, or not? And these imaging agents can help make that determination. It's also important to know that while amyloid is, if you will, sort of the trigger to starting the disease of Alzheimer's disease, that tau is the biomarker that's more related than amyloid to the kind of cognitive impairments patients have, the pattern of amyloid in the brain telling you which lobes are affected and what sort of cognitive functions are more likely to be altered, and the rate of decline. The more tau you have, the faster you go down, and the more tau you have, particularly in the frontal lobes, the more rapidly people are likely to decline. So that's a real important asset. So from our perspective, from the clinical trial perspective, using biomarkers have really helped us identify the biological targets that we want our drugs to attack, to identify the patients that are appropriate for clinical trials, and finally, just in the last few months, identifying effective treatments. Thank you very much.
Gina, do you have a question? Oh, here's the question. Is this imaging useful for guiding treatment decisions or only for medical research?
That's a great question. So let me back up a little bit here. One more. There we go. At the moment, the correct answer is for medical research. However, it has been proposed in both the aducanumab work and the donanemab work that once your drug has removed all detectable amyloid, you can see that the scale on the far left goes from 0 to minus 100. If you remove 100% amyloid, which it looks like donanemab has done, and maybe aducanumab has certainly done, the question is that the time to stop using the treatment drug? The patients don't have amyloid any longer. Do you really need to continue giving them these infusions to remove amyloid? There is components of both Biogen and Lilly trials that are looking at that question. I think the suspicion is that yes, amyloid imaging would be used prospectively to decide whether you can reduce the dose or eliminate treatment in patients for whom fully removed amyloid has been documented. I will say that all of the people who are using these techniques are following the patients from these phase 3 trials in a long-term fashion with discontinuation of their drugs to find out, does amyloid stay down permanently or does it stay down for a couple of years? And you might want to rescan a patient every once in a while to see whether initiation of therapy is needed again. Those are unanswered questions that should be answered in the next 2 to 3 years.
Do you know, does Medicare cover these PET scans?
That's a wonderful question and could easily get me on a soapbox. No, they do not. They have declined to cover them since they were first approved by the FDA, in some cases as much as 10 years ago. And that's unfortunate in my mind because getting an accurate diagnosis for a patient is an important thing to do. There are beyond the role of interventional therapies. I think it's important to be able to tell exactly what is causing cognitive impairment in a patient so that the patient and their caregivers and their families can make important planning decisions. But CMS has declined to approve any of these agents for reimbursement. It is often said, not by CMS yet, that in the face of a therapeutic drug that requires evidence of amyloid in the brain of the patient to receive the drug, that CMS will approve the amyloid imaging agents. There are three different manufacturers have FDA approved drugs, and we think that all three will be approved. Will be reimbursed once CMS makes its decisions about reimbursement for aducanumab, which we're expecting sort of any day now, given that the drug was approved by the FDA in early June.
Are these new drugs mainly used for early onset Alzheimer's?
Yes, the companies Biogen and Lilly have focused on mild to moderate AD and on MCI patients. And so I think the answer would be yes. I would like to say sort of almost philosophically that given the success at removing amyloid and the success, at least when you target the right patients, of limiting the accumulation of tau, suggests that the farther back in time that you could start this therapy, the more likely you are to have even greater impact on cognitive decline, maybe even arresting it, and perhaps preventing further accumulation. We have no data to say that's true, but understanding the biology of the disease suggests that that should be the case. So you could imagine doing these trials in patients who have only mild cognitive impairment, or even in cognitively normal subjects who have the biomarkers but not yet cognitive change. There are some research trials exploring those questions, but we don't know the answers because those trials are not yet complete.
Obviously, treatment is the priority of current research, but can these drugs potentially be used for prevention? Amyloid appears so much earlier than symptoms. Could this be a possibility?
Yeah, that's kind of what I was saying a minute ago, but not perhaps in too much doctor speak. If you could find people whose brains are still intact, who have amyloid, but it hasn't started developing tau, or the cells are still pretty healthy, and you could arrest the amyloid accumulation at that moment, I personally believe that you could prevent the actual disease from occurring.
And one more question. Could you please repeat the distinction between MRI and the other treatment and its applicability?
Sure. So MRI is a technique that mostly measures brain structures. You can use it to measure aspects of brain function as well, so-called fMRI, functional MRI. But MRI is an exquisite technique for identifying tumors or other structural changes in the brain that could be underlying a cognitive impairment. And so in clinical practice, it is primarily used in cognitive impaired patients to see whether there's a structural cause for that cognitive impairment. PET imaging or other functional imaging measures are used once you've ruled out structural causes to see whether the underlying cause might be Alzheimer's disease or some other neurodegenerative disorder.
Thank you very much, Dr. Devous. We're out of time. We're going to take a short break and then we'll get back to our third breakout session. Thank you, everyone.
Thanks, folks.